Hello, everyone, and welcome to our webinar series, To Immunity and Beyond, focusing on immunity and infection in donation and transplantation. My name is Erica, and I will be today's moderator. First of all, I'd like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, a traditional gathering place for the diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saluto, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I encourage you to write your land acknowledgement in the chat box. We'd also like to acknowledge CIHR, whose generous support enabled us to host these sessions. Today's session is recorded and posted on CDTRP website and news YouTube channel. During the presentation, please keep your mics off. If you have a question or comment, you can raise your hand with the raise hand button or type it directly in the comment section. Today, we're pleased to have three PhD candidates, Aisha Adill, Amy Thachil, and Louis Vanpeperstraete, present their second primer webinar titled Immunology of Infections and Treatments in Organ Transplantation. Aisha is a second-year PhD candidate in the Department of Laboratory Medicine and Pathobiology at the University of Toronto, co-supervised by Drs. Michel Bendeck and Paul Santerre. Her doctorate focuses on nanoparticle drug delivery for the treatment of vascular occlusive diseases in children and adults. Amy is a PhD candidate in the laboratory of Dr. Tom Blight Hansen at the BC Children's Hospital Research Institute. Her work focuses on immune metabolic biomarkers of transplant outcomes in kidney transplant recipients. Louis is a PhD candidate in immunology and microbiology at the Université de Montréal with Dr. Marie-Josée Hébert. His doctorate focuses on the role of complement systems after renal ischemia, reperfusion, and aging. His work aims to identify mechanisms to reduce long-term loss of kidney graft function. Speaking for myself and hopefully many others, I'm very excited about your presentation. I will now hand it over to you.
Thank you, Erica. I'm just sharing my screen here. Just making sure. Okay, perfect. So, hi everyone. Thank you for attending our, apologies. Just making sure you can still see my screen?
Yep.
Okay. So thank you for attending our seminar today. As Erica mentioned, my name is Amy. I'm a first-year PhD student at the University of British Columbia, and I'm just going to let Aisha and Louis introduce themselves.
Hi all, my name is Aisha. As Erica introduced, I'm a PhD candidate at the University of Toronto.
Bonjour, mon nom c'est Louis et je suis étudiant en doctorat à l'Université de Montréal.
So our talk today is entitled Immunology of Infections and Treatments in Organ Transplantation. This webinar is going to be presented in both English and French, and there is an automatic translation option available on Zoom. You can see the icon for that over here on the screen, and you can feel free to click on this at any time in the presentation so that you can follow along in the language of your preference. And if you have any questions related to this, or if you're experiencing any difficulties, feel free to let us know in the chat and someone will be able to help you. So for today's talk, we're going to begin by discussing some of the basic concepts related to infection and also go over some of the nuances that are specific to transplantation. Louis is going to talk you through vaccination and the use of antibiotics. And finally, Aisha will cover some cancer considerations in transplant recipients and also go over graft versus host disease. Some of what we talk about today will build upon some concepts that we introduced during our first seminar. Specifically, we went over the immune system and its role in protecting the body. We discussed the immune system in the context of transplantation and how there's a balance to be struck in terms of allowing the recipient's immune system to retain its protective functions whilst also being able to tolerate the newly transplanted organ. Adaptive immune systems and the different components that are involved in those two arms of the immune system. And then finally, we went over the use of immunosuppression medications and how that could contribute to susceptibility to infection and cancer risks, as well as some emerging therapies that are a bit more targeted and move away from broad suppression of the immune system, including cell-based therapies, cytokine targeting treatments, tolerance-inducing strategies, and immune checkpoint inhibitors. So we want to begin today by discussing a simple question. So what is an infection? Broadly speaking, an infection occurs when harmful microorganisms, so things like bacteria, viruses, fungi, when they enter the body and they begin to grow and multiply. Not all microorganisms are harmful. Some of these microorganisms can be beneficial, but when harmful or pathogenic microorganisms enter the body and begin to grow and multiply, they impact the way our body functions, and they can result in infection and the different symptoms that are associated with infection. So things like fever, cough, fatigue. And in under healthy circumstances, the immune system is able to combat these harmful pathogens and prevent infection. But when the immune system is suppressed, such as when immunosuppressive medications are being taken, it's not able to do so. And so that leads to infection and susceptibility to infection. Taking a closer look at the different microorganisms that can cause infection, we're starting off here with bacteria. So bacteria are small single-cellular organisms that can live in a variety of different environments. So we have bacteria that are naturally occurring on our skin and within our bodies, as well as on different surfaces that we might be in contact with right now. And some of these bacteria can be harmful and cause disease, but some of them are actually helpful, and they can help with things like digestion, and they can even help in the development and strengthening our immune system. In some instances, bacterial infections need to be treated using antibiotics, which will kill and prevent the bacteria from growing and multiplying. And Louis is going to speak about this in a bit more detail later on in the talk. So when we consider microorganisms that are beneficial, we wanted to touch upon the microbiome. So the microbiome is a collection of microorganisms that exist on and within our bodies. The microbiome is predominantly composed of bacteria. So there are harmful bacteria, or sorry, there are beneficial bacteria that help with things such as digestion and strengthening the immune system. But there are also bacteria within the microbiome that could potentially be harmful and could potentially be pathogenic. But they're typically kept in check by the immune system, as well as through competition with the beneficial bacteria. And in a healthy individual, there's a balance between the potentially harmful bacteria and the beneficial bacteria. But in some cases, this balance can be disrupted, and that leads to a state of dysbiosis. And in dysbiosis, different diseases can be caused, such as inflammatory bowel disease, but you also have an increased susceptibility to infection. And in transplant recipients, this is particularly important because the use of immunosuppressive medications, as well as taking antibiotics to treat bacterial infections, that can disrupt the microbiome. And this disruption, this imbalance, can increase susceptibility to infection. Moving on to viruses. So viruses are much smaller than bacteria, and they're made up of genetic materials, so either DNA or RNA that's encapsulated within a protein coat. Viruses require a host cell or a human cell, in this case, in order to be able to survive and reproduce. And when a virus infects a human cell, it's able to hijack that cell's machinery and use it to replicate and produce more copies of the virus, which can then go and infect additional cells within the body and cause spread of the infection. Viral infections are sometimes treated with the use of antiviral medications. And it's also just important to note that there are some viruses that exist within our body, but they're dormant. So they're not actively replicating and spreading and causing infection, but they are still within us and they remain dormant. And this is going to become relevant later on in the talk. Finally, we have fungal and parasitic infections. So fungal infections include things such as a yeast infection and different molds that can infect the skin, lungs, and other parts of the body. We also have parasitic infections. So parasites live on or inside other organisms, and they use them as a source of nutrients in order to be able to survive. And parasites can be spread through potentially contaminated foods or water. And again, typically the immune system is able to uh, keep these harmful microorganisms in check and prevent infection. But when the immune system is suppressed, these infections can be a bit more severe, perhaps even more difficult to treat, and require some additional clinical care. When it comes to fighting infection, we touched upon this during our previous seminar, but once a pathogenic bacteria or virus is detected by the immune system recognizes it as non-self and mounts an immune response against it. And there are two different arms of the immune system, the innate immune system and the adaptive immune system, both of which work towards clearing the pathogen from our system. So, over the course of an infection, during the initial invasion, when the pathogen is initially encountered, innate immune mechanisms come into play. And if the pathogen isn't effectively cleared, that's when adaptive mechanisms come into play. And this includes mechanisms mediated by B cells and T cells. And then finally, there's an immune response, a memory response that is developed. And I just wanted to quickly mention, as it relates to the memory response, that it's mediated primarily by B cells, memory B cells and memory T cells that exist within our circulation and are able to recognize and more quickly and efficiently clear the pathogen from our system if it's encountered a subsequent time. So specifically considering infection risk post-transplant, as we mentioned, transplant recipients are at increased risk of infection because they're taking immunosuppressive medications post-transplant, which broadly suppress their immune system. And these medications are important because they allow the recipient to better tolerate their newly transplanted organ, but they reduce the body's ability to effectively fight and clear infections. There are other factors that contribute to infection risk post-transplant. So factors related to the surgical procedure itself, exposure to the hospital environment, and potentially the use of different medical devices such as catheters. These can all also contribute to infection risk post-transplant. And in terms of immunosuppression, post-transplant immunosuppression is given in different phases. So there's a high intensity phase at the time of transplant that helps prepare the body for the transplant and prevents immediate rejection of the transplant. There's a maintenance phase, which is typically a lower dose of immunosuppression, but it's given long-term, often lifelong, and it's to help the recipient maintain their transplant. And finally, if rejection does occur, higher doses of immunosuppression are given, as well as steroids that can influence infection susceptibility. In terms of common infections that could be encountered after a transplant, we have bacterial infections that can cause pneumonia or urinary tract infections. There are viral infections, so we could have reactivation of some of those dormant viruses that I mentioned, such as CMV. Those could become reactivated and cause a viral infection, as well as susceptibility to different respiratory viruses. Fungal infections are not as common, but again, things like yeast infections could occur post-transplant. In terms of the infection trajectory post-transplant, in the immediate post-transplant period, infection risk is often related to surgical or hospital exposure factors, and often we'll see bacterial infections during this time period. During the early post-transplant period, infection risk is related to the level of immunosuppression, and recipients might be susceptible to opportunistic infections, which Aisha is going to explain in more detail later on in the talk. And then finally, after this period, recipients are susceptible to community infections, and that's similar to the general population. And infection risk is again here related to the level of immunosuppression that they are being given. And with that, I'm going to pass things off to Louis, who's going to talk us through vaccination.
Alors, pour définir la vaccination, on va tout simplement prendre la définition de Santé Canada. La définition simple de Santé Canada, c'est que des vaccins, c'est des produits qui sont biologiques, qui sont complexes et qui permettent de déclencher une manière sûre et surtout efficace une réponse immunitaire qui va nous protéger contre les maladies. Cette définition-là, elle omet surtout l'essentiel, c'est que ça nous permet de nous protéger nous-mêmes et également de nous protéger toute la société. Et si on parle de protection à l'échelle de la société, eh bien, comme vous le savez tous, comme on le sait tous, quelqu'un qui est malade et qui est en contact avec des personnes qui ne sont pas protégées ou qui ne sont pas vaccinées, eh bien, ça va permettre le développement facile et très rapide d'une maladie. Si par contre on a une population qui est partiellement vaccinée, on va ralentir cette maladie. C'est ce qu'on peut voir sur la deuxième image ici. Et si on arrive à atteindre ce seuil de vaccination, eh bien, et que la personne malade, eh bien, elle ne pourra pas contaminer qui que ce soit. C'est ce que on cherche à obtenir là, à travers toutes les campagnes de vaccination qu'on peut avoir concernant les différents types de maladies pour justement éviter qu'il y ait quelqu'un d'autre qui soit contaminé. Donc, on va aussi également se demander quelle est la composition de ces vaccins. Donc, dans un vaccin, on va avoir des composés actifs. Donc, on va revenir après sur la définition même de ces composés. Donc, on va avoir des adjuvants. Ces adjuvants, ils vont permettre d'activer une réponse immunitaire et justement de pouvoir laisser l'organisme euh, euh, des stabilisateurs, des composés qui vont permettre de sécuriser le vaccin. Et on va également avoir des antibiotiques qui vont également permettre de protéger le produit avant qu'il soit vacciné chez des individus. Donc concrètement, que représente que fait le vaccin dans notre corps? Eh bien, dès qu'on va recevoir l'injection, on va d'abord des antigènes qui vont être relâchés. Ces antigènes, comme on vous l'a exposé il y a 2 semaines auparavant, eh bien, ça va permettre ce sont des composés qui sont reconnus par l'organisme comme du non-soi. Ces composés vont ensuite être reconnus par des cellules présentatrices d'antigènes. Comme on vous a exposé la semaine passée, ça va permettre justement d'être reconnu par l'organisme. On va par la suite avoir une activation de l'ensemble de nos cellules, donc principalement nos cellules T, qui sont surtout dans un rôle de régulation de l'inflammation euh, et aussi de la régulation de l'inflammation. Et on va également avoir une activation des cellules B qui vont permettre, ce sont ces cellules-là qu'on va reconnaître pour induire la réponse aux anticorps. Et tout cela, en fait, on reproduit toute cette activation-là, surtout pour induire une mémoire immunitaire, comme l'a précisé Amy au début de sa présentation. Donc, je vous ai parlé plutôt de composés actifs. Donc, très brièvement, quels sont ces composés actifs? On a, comme vous pouvez le voir tout à gauche, des composés actifs qui sont dits vivants ou vivants atténués. Eh bien, ça, c'est des composés, en fait, c'est le vrai virus qu'on va prendre et qu'on va affaiblir ou qu'on va entièrement tuer et qu'on va ensuite qu'on va ensuite s'injecter pour directement reconnaître le virus, vu que c'est le même virus. On va également avoir euh, des vaccins dits recombinants. Eh bien, en fait, là, ce sont des protéines qui sont faites en laboratoire et qui vont permettre de reformer quelque chose qui existe chez le virus. Autre chose qui existe dans les types de virus, ce sont les virus à vecteurs viraux. Donc ça, c'est simplement pour dire que c'est un virus qui est non pathogène, qui est sécurisé, qui ne contient pas ce qui permet d'induire une maladie, mais qui représente, qui peut être reconnu facilement grâce aux antigènes à sa surface. Et la dernière solution possible, c'est les acides nucléiques, donc les vaccins à ADN ou à ARN. Cela, en fait, ça va nous donner simplement le code génétique pour demander à nos propres cellules de reproduire eux-mêmes des vaccins qui sont très bien utilisés depuis très longtemps et qui continuent d'être développés. Mais alors, concrètement, chez les patients transplantés, qu'est-ce qu'on va préconiser de faire? Eh bien, d'abord, on va préconiser quand c'est possible, de le faire avant la transplantation. Quand le système immunitaire est encore intact. C'est également comme je l'ai dit, l'échelle de la société est également très important. Donc, on va demander à l'entourage proche de se faire vacciner. Et on va déconseiller très fortement de faire les vaccins, le premier type de vaccin qui représente un petit peu un risque plus féroce. Mais on va également avoir une forte recommandation pour continuer la vaccination même en étant transplanté. Donc ensuite, on va vous parler des antibiotiques. Alors les antibiotiques, ce sont des médicaments qui sont utilisés contre les infections bactériennes et uniquement contre les bactéries, qui ne sont pas efficaces contre les virus. Comment ces médicaments fonctionnent? Eh bien, ces médicaments fonctionnent soit en tuant directement les bactéries, soit en inhibant la croissance des bactéries. Et en inhibant la croissance des bactéries, ça va nous laisser l'organisme et tout notre système immunitaire, ça va lui laisser le temps d'aller attaquer ces bactéries. Il faut savoir aussi que ces antibiotiques, ils vont cibler uniquement des composés bactériens. Ça ne va pas cibler des composés humains, donc des cellules humaines. Et également, il est très important de les utiliser de manière appropriée parce que, on va voir ça juste après, parce que c'est quand même très important. Comment on doit prendre ces médicaments? Eh bien, il y a des doses, il y a des prescriptions et également des très fréquences. Il y a des fréquences à respecter de manière très importante. Il est très important également de ne pas les prendre, de ne pas arrêter de les prendre trop tôt, parce que même si on se sent bien, il faut les prendre en continuité pour éviter qu'il y ait toujours des bactéries pathogènes et dangereuses qui restent et qui puissent se développer à nouveau. Et chaque traitement antibiotique est dirigé contre un type de bactérie. Et cela, ça veut dire qu'il ne faut pas réutiliser par nous-mêmes des traitements antibiotiques par nous-mêmes parce qu'on ne peut pas forcément bien cibler la bonne bactérie, ce qui représente en fait un risque pour nous. Donc, il y a les antibiotiques, c'est aussi dangereux de base parce que ça va cibler toutes les bactéries. Également, les bactéries que Amy vous a présentées, c'est-à-dire les bactéries du microbiote, qui elles sont très protectrices et elles nous aident beaucoup à digérer. Et ici, c'est une image extraite d'une étude qui a justement comparé des images des patients qui ont reçu des vaccins et avec ou sans antibiotiques. Ils ont pu voir que le, euh, à prendre des antibiotiques, ben en fait, ça engendre un grand nombre de problèmes. Donc, on va avoir des problèmes au niveau du sang, on va bien sûr des problèmes au niveau du microbiote et toutes des conséquences à la digestion et également avoir une inflammation. Les antibiotiques, il y a également une autre facette qui est beaucoup plus dangereuse, c'est que les bactéries peuvent apprendre en quelque sorte à, euh, à résister contre les antibiotiques. Donc ça veut dire que elles vont ne plus mourir, elles vont continuer à se développer même si on donne ce traitement. Euh, si tu veux revenir là. On va, Ça peut représenter un danger d'abord pour nous-mêmes parce que ça veut dire qu'on a une infection bactérienne et que le traitement n'est plus efficace. Et ça représente également une échelle de la société parce que une bactérie qui n'est plus susceptible de mourir un, par un traitement va pouvoir se développer et toujours se transmettre de personne en personne. Ce qui donc incite de plus en plus à limiter ce risque de, euh, de, euh, de résistance. Et il faut également noter qu'on peut avoir, et ça c'est de nouveaux traitements qui sont en train d'être étudiés, l'utilisation de virus dirigés contre les bactéries. Mais alors, chez les patients transplantés, comment cela se passe? Eh bien, en fait, comme vous le savez, les patients transplantés sont à risque d'infection, que ce soit d'une part par leur condition médicale, d'autre part en raison de l'immunosuppression ou juste le fait d'être dans un milieu hospitalier. C'est également un risque, il y a un risque d'avoir des maladies dites opportunistes vont se développer uniquement suite à l'une de ces raisons précédentes. Et donc, comme les meilleures solutions, bien entendu, ce sont la prévention qu'on peut faire avant et après la transplantation. Dans la population transplantée, on va également chercher à porter un plus grand monitoring, surtout en particulier de la fonction rénale et en grande particulier chez les patients qui ont reçu une greffe du rein parce que ce médicament-là a également des conséquences au niveau rénal. Et donc, généralement, ça veut simplement dire euh, ça demande une plus grande précaution pour l'usage de ces médicaments dans ce contexte particulier.
Now we'll shift over into the applications of what we've learned in the first and second webinars thus far, both from Louis and from Amy that we've heard earlier as well. When you think about key immunity challenges, these can be multifold and with multiple challenges, including some examples of what we'll go over today, such as opportunistic infections, virally induced malignancies, such as Epstein-Barr virus, HPV, as well as having elevated cancer and graft versus host disease risk. Opportunistic infections, to start off with, these can be caused by pathogens that take advantage of the suppressed immunity. And these can commonly occur anywhere from 1 month to 1 year post-transplant. And they definitely have multifold applications. These viruses can not only cause direct damage, so in other words, having a tissue invasion, but they can indirectly deepen the immunosuppression. So it predisposes patients to secondary infections and even increases the risk of graft rejection or malignancies. Now, putting some background to the basics that Amy introduced earlier, there are different types of opportunistic infections that can occur. There are certain viruses that can occur, such as cytomegalovirus, CMV, being the most common. Fungal infections, which are a leading cause of mortality in transplant patients, and they can be often hard to treat, with the aspergillus species being a notable one that causes rapid necrotizing pneumonia. There are also rare bacteria that can lead to opportunistic infection. There are also dormant infections from the donor or recipient that can re-emerge in the immunocompromised environment. Infections, in terms of opportunistic infections, often progress much faster in transplant recipients than in the general populations, and there are muted signs and symptoms which can make this more severe and harder to treat. We saw this in our first webinar, but we are bringing this back when we start to discuss cancer risk in organ transplantation. There's a delicate balance that we have to strike. There's long-term immunosuppressive drugs that are required, such as calcineurin inhibitors, steroids, that are used to prevent graft rejection. But these medications also weaken the body's ability to detect and destroy malignant cells, allowing cancers to develop and grow. But treating these cancers can often require reducing the immunosuppression dose to allow the immune system to attack the tumor. However, lowering these drugs can trigger acute or chronic rejection of the transplanted organ. So as you can just listen to me here, there's this delicate immunological balance that we need to strike. Keeping this balance in mind, there are some particular challenges within the organ transplant community with respect to cancer. Solid organ transplant recipients have a 2 to 4 times higher risk of developing cancer. In particular, heart and lung transplant patients have a 3 to 4 times higher risk of cancer relative to the general population. And rejection rates are much higher in patients that are receiving immunotherapy after the transplant. And those with a pre-existing cancer diagnosis have approximately 4% increased risk of post-transplant cancer reoccurrence. And this is often due to the off balance that is between the medications and treating cancer. In terms of cancers in transplant patients, they behave much more regressively, they have faster progression, and have a higher likelihood of metastasis compared to some of the same cancers in the general population, partly because there's an impaired immune response. In terms of virally induced cancers, immunosuppressed patients are vulnerable to more infections, particularly oncogenic viruses such as the Epstein-Barr virus, human papillomavirus, and Kaposi sarcoma-associated herpes virus, or HHV8. And these viruses can lead to post-transplant lymphoproliferative disorder, lymphomas, and Kaposi sarcoma. And in some rare cases, cancer cells from the donors can be transplanted, and this is due to the immune suppressed system of the recipient. So these are donor-derived cancer transmission occurring in less than about 1% of cases, but these can eventually develop into a full cancer. So the question that comes up is, what can we do? Now, there are several promising immunotherapy approaches that are currently explored in the transplantation field, and we went over these in the previous webinar, but drawing our focus back to the immune checkpoint inhibitors on the far left, which is specifically for patients that develop cancer. As a quick re-jog of our memory from our first webinar, this treatment is intended for transplant patients who develop cancer due to lifelong immunosuppression. And these immune checkpoint inhibitors work by blocking the checkpoint proteins on T cells. So examples include PD-1, PD-L1, and CTLA-4. And generally, under normal circumstances, these checkpoint inhibitors are acting as regulatory brakes on the immune system. And by blocking these checkpoint inhibitors, by blocking these checkpoint pathways, these checkpoint inhibitors are enhancing the T cell activity by allowing the immune system to effectively recognize and destroy cancer cells. Now, while immune checkpoint inhibitors like anti-PD-1 and anti-CTLA-4 are effective against cancer, they do cause graft rejection up to about 40% in kidney transplant patients by breaking that transplant tolerance. And generally, rejection rates are higher, approximately reaching 40% with anti-PD-1 therapy. When discussing management and mitigation strategies for cancer care, this involves a complex multidisciplinary approach that balances, again, that reduction of the immunosuppression to fight the cancer while maintaining that adequate immune function to prevent the organ rejection. So reducing the overall immunosuppressive load is generally the first step that it comes upon a cancer diagnosis, particularly for cancers that do respond to immune recovery. So some approaches include converting from some immunosuppressants to others, to different classes, such as converting from calcineurin inhibitors or antimetabolites to mTOR inhibitors. So examples include sirolimus or everolimus. And this is a primary strategy because these mTOR inhibitors, they possess anti-angiogenic, anti-neoplastic properties, which can help manage the malignancies while still providing immunosuppression. In terms of high-risk patients, reducing or avoiding T-cell depleting biological agents is also particularly important when discussing alternative immunosuppressants. Regular and often more frequent screening is required for post-transplant cancer, sometimes even requiring chemoprotective agents. So managing cancer in this population requires a multi-team approach, requiring often oncologists, nephrologists, dermatologists to really weigh the risk of the cancer against the risk of graft failure. So having targeted care as well as surveillance and routine monitoring is absolutely key in terms of managing. Now, shifting over to graft versus host disease, we saw this on the first slide of the immunity challenges. This is where donor immune cells attack the recipient's tissues, often targeting areas such as the GI tract, the liver, and the skin. And this is really stemming from a quote-unquote double hit scenario, in that it's a common theme that we've been hearing about. There's severe immunosuppression that's needed to manage the graft versus host disease and the damage that the graft versus host disease itself is causing to the immune system. And this is because when donor T lymphocytes view the recipient's tissues as foreign, they attack them, and that causes significant damage to the organs that we mentioned, such as the skin, liver, the GI tract. And a quick catch-all statement to think about with graft versus host disease in organ transplant patients is that it's rare to occur, there's high mortality, there's poor prognosis. Graft versus host disease after solid organ transplant, so for example, after a liver transplant, it's rare. It occurs around anywhere from 0.1 to 2%, but it has an extremely high mortality rate ranging to about 85 to 90%. And the challenge here is that once there's acute graft versus host disease that fails to respond to the initial steroid treatment, for example, it carries a pretty dismissal prognosis, and signaling therapies are often ineffective. At a cellular level, we want to think about what graft versus host really is doing to lead to these high mortality and poor prognoses that we just heard about. Graft versus host disease, it damages the thymus and the bone marrow. So that means that it inhibits the regeneration of new T and B cells, which impairs T cell recovery, increasing the vulnerability to opportunistic infections. You can start to see that there's a link between some of the challenges we started to discuss. Donor T cell recovery does become slow, so patients do remain with a weakened immune system for several months to years. It is also damage to secondary lymphoid organs in that the graft versus host disease will impair fibroblastic stromal cells, and these are within the lymph node and the spleen. And again, that's really targeting the body's ability to produce naive and B cells. And so that unfortunately becomes impaired with graft versus host disease. So there's a very high risk of life-threatening infections, which often becomes exacerbated with steroid use. In terms of complications and taking a transition into what we really see on a clinical front, there's treatment side effects that come with graft versus host disease treatment, and that steroids and calcineurin inhibitors are the first line of treatment, but they further weaken the immune system. Older patients have a much higher risk of developing graft versus host disease, and that number can go up to 9 times more or 9-fold more. Patients are subjected to cytopenias or pancytopenia. There's increased risk of recurrent bacterial infections. We have common clinical signs such as skin rash, diarrhea, liver dysfunction, and these are non-specific and they often mimic viral infections or drug reactions, so it becomes difficult to diagnose graft versus host disease. These can also cause a spleen to stop working properly, which we just heard about. So that does leave a body vulnerable to specific bacterial infections. They can also lead to inflammation and fibrosis, or in other words, scarring, particularly in the lungs and the GI tract, which can cause severe nutritional deficiencies as well as develop chronic infection sites. Remembering our first part of that catch-all statement, this is a rare occurrence. So treatment and management strategies for graft versus host disease require promptness. The first line of therapy is specifically focusing on immediate immunosuppression to halt that donor T cell activity. So that first line treatment involves receiving high-dose corticosteroids, so for example, prednisone, while second line therapies, if for example, the steroids do not work, these are applied for refractory cases or when steroids don't work, including targeting or reducing the T cell activity. There's removal of white blood cells through extracorporeal photopheresis and other treatments that are available. But generally, when it comes to graft versus host disease, this requires skin biopsies, oral biopsies, pulmonary function tests, which are used to diagnose and grade the graft versus host disease. And so that can help localized therapy, such as having topical treatments to target skin-involved graft versus host disease. But in general, prophylactic immunosuppressive medications are routinely used to prevent graft versus host from occurring. In other words, preventing the donor cells from attacking the recipient tissues. But overall, promptness and being quick to identify graft versus host disease is absolutely key when it comes to management. So we hope that with these first 2 webinars, especially today, we were able to tell you a lot more about the transplantation and immunosuppression and what happens to the body as it responds to infection. Immunosuppression is absolutely essential, but it comes with trade-offs. We're calling that delicate balance that we have to strike across different immunity challenges as well as different conditions that do arise within the organ transplant community. Vaccination, safe practices, and early treatments such as antibiotics and antivirals that Louis went over have a major role in staying healthy. And recognizing your symptoms and regular follow-ups are really crucial to managing the risks that come with organ transplantation, such as infections, cancers, and complications such as graft versus host disease. So I'll end it off there with a quick take-home message, and I'll turn it over for questions. And before we just do a quick reminder that our next webinar will be April 16th, but opening it up now for questions. Thank you.
Thank you, everyone, for that excellent presentation. I will now open the floor to any questions. I'm going to start us off with a question, though. So, in your presentation, you explained early on that vaccines work by building immunological memory through B and T cells. How does the process of memory cell formation differ between a natural infection and a vaccine?
Amy, est-ce que tu veux ou je peux commencer à répondre si tu le souhaites? Donc, vas-y.
Oh, sorry, Louis, you can go ahead.
Donc, la question de savoir quelle est la différence entre l'activation du système immunitaire par un vrai virus versus un vaccin, eh bien, en fait, il n'y a pas tant de différence. La seule différence qu'on va avoir, bah, c'est sur le risque. Un vrai virus représente un vrai risque, alors qu'un vaccin représente un risque nul ou très faible. Et au terme, en niveau cellulaire, ça peut représenter euh, vraiment, c'est les mêmes antigènes qui sont qui permettent d'éduquer nos cellules, que ce soit un vrai virus ou un antigène qui vient d'un vaccin. Et nos cellules mémoire, que ce soit nos cellules T ou nos cellules B, sont capables de reconnaître indifféremment, que ce soit un, un vrai virus ou un vaccin qui va venir plus tard. C'est même à ça qu'on peut reconnaître si un vaccin est efficace ou non, si on peut entraîner une bonne mémoire immunitaire robuste.
Sorry, I don't have anything to add to that, Erica.
No, it was an excellent answer.
I mean, if you want an English version, I can add a few details about B and T cell functions, if you're interested.
Yeah, go for it.
Perfect. I obviously cannot translate everything that Louis said, but just generally from what I've read and some things that I know about, vaccines are really just creating that wanted poster of a pathogen. So they're not really subjecting the body to a full-scale battle. So it's really just having these really high affinity memory cells to form without having that severe tissue damage that normally happens if you had, like, say, for example, a natural infection occurring. And when you think about B and T cells, so vaccines are often targeting much specifically, and this is because of the way it's been designed. And so there's a much more higher affinity of memory B cells that form as a result. So as a result, the antibody response that you get in response to a vaccine, it's going to be much more narrow in scope than opposed to, for example, a response to a natural infection. Versus in a natural infection, you're having antibodies stringing multiple parts of the virus. Some vaccines are long-lasting, and they have much more long-lived induced T cell formation. So that does provide sustained immunity for several months to years. And that, keeping in mind with the natural response, sometimes that matches or even exceeds the normal cells that are found after a natural infection. And another aspect to think about is maybe like durability and conservation. So antibodies can persist, but when it comes to vaccination, the peak antibody response that you get, it will wane much faster after a vaccination as opposed to like a natural infection. And you can think back to some of the maps that Amy showed earlier. And in terms of conservation, the response that you have at a T cell or B cell level, these are much more conserved across different variants that you get. So you have a bit more of like in other words, a durable protection against severe disease, even when you have neutralizing responses within our body, like neutralizing B cell responses, these are reduced. So that's just a very quick, specific answer in English.
Thank you very much. Do we have any other questions from the audience members? If not, I can ask another one. So you mentioned transplant recipients frequently take antibiotics for prevention. Given the overuse acceleration of antibiotics resistance, how do clinicians balance the prophylactic antibiotic use with the growing public concern of resistance?
Admittedly, I don't think any of us are too familiar with what happens on the clinical side, but I imagine it's through close monitoring of the recipient's response to the antibiotics as well as their overall graft function. I imagine plays a big role in establishing that clinical balance. Louis and Aisha, I don't know if you have anything to add to that.
Oui, eh bien, il va également y avoir un facteur de, par exemple, de contexte, euh, que ce soit chez la population transplantée comme n'importe qui, quand on doit avoir des traitements pour les dents, eh bien, c'est aussi préconisé de donner dans des conditions un traitement antibiotique. Donc, c'est vraiment contexte dépendant et personne dépendante.
Yeah, and just adding a little bit more, we have to keep that term of specificity in mind when discussing that balance. So you really have to reduce that broad spectrum use or the unnecessary usage. So some strategies I think clinicians do take is that they delay the prescription. So you could really provide that prescription if you're seeing that symptoms are specific or they're worsening specific to the condition. Or you could even choose much more narrow spectrum antibiotics to ensure that the target is specific to what you're targeting, as opposed to giving broad spectrum, and that could unfortunately lead to the resistance and the challenges that we see generally. The other thing is that there's shorter durations that targeting infections to help reduce that resistance. But again, that would rely on the clinician's specific knowledge and background to make sure that they're taking more of a specific approach and something that is much more targeted to ensure that that resistance doesn't build up and we don't go toward that broad spectrum or inappropriate usage that we typically encounter.
Thank you. I am opening the floor again for the audience members. If not, I have one last question. And if I don't have any others, then I will call it there. So if you have any last questions, raise your hand now. My question is, so you describe immunosuppression as both essential for projecting, no. You describe immunosuppression as both essential for preventing rejection and a major risk for infection. How do they decide to adjust the patient's immunosuppression levels? Like, let's say they found an infection or cancer is detected.
So we went over this in more general terms throughout the talk in terms of like different infections and different conditions that do come up. But generally, when it comes to management and mitigation strategies, there's already a multi-clinician approach or a team approach that comes with management. And it involves multiple different specialists, but generally it's looking at what can you suppress and immediately target quickly. So typically, for example, if there's a cancer or if there's some certain infection, the first approach is, okay, how do we quickly grasp it and control it so that it doesn't affect the body further? Because we have to keep in mind, and this is probably the first thing we should have in mind, is that we already are dealing with a delayed immune response. We are already having an immune suppressed environment. So having an additional layer of that infection is a huge risk that we want to target immediately so that we can control it. Otherwise, there's going to be that collateral damage, and it's almost like a domino effect that comes with it. So there's already a multi-team approach. And one thing to keep in mind, and generally that comes up with my rating when we were discussing immunity challenges, is that there's already chemoprotective agents and prophylactic measures that are taken in general care when we're looking at graft rejection and generally managing a graft after transplant. So a lot of these medications and approaches have multi-targets, and that they can help already target some of the infections that might occur. However, again, just going back to the first point, it's really just making sure that when something does come up, it's targeted, it's very specific, and we just are able to minimize the risk of infection and eliminate it as quickly as possible. There are obviously cases where this does progress or these infections can persist along with treatment. Then it looks more specifically on a patient-to-patient specificity. How is the patient going to be able to tolerate There's different tolerances, obviously, to medications and how patients are able to respond to dosages, obviously, keep in mind. But then it just becomes, okay, let's trial and test, look at what can be applied between the two and where the patient is able to tolerate and to what extent we can go with the treatment.
Thank you. Okay, so Amy, Aisha, and Louis, on behalf of CTTRP, thank you again for presenting. If anybody has any additional questions or comments or suggested speaker topics, please contact myself at ekcroft@live.ca. Thank you everyone for joining, and we do hope to see you all at our next presentation on April 16th. We will have Drs. Mamitha Bhatt and Dr. Samita Ghosh present their research on leveraging AI for biomarkers identification in liver graft pathology. Enjoy the rest of your day. Thank you.